The IsoGuard system was developed to allow surgeons to perform minimally invasive Morton's Neuroma decompressions and plantar fasciotomies. The system includes 4 instruments and a single-use blade. The instruments are the tissue locator, which is used for both intermetatarsal nerve decompression and plantar fasciotomy. Its purpose is to assist in locating the underlying edge of the transverse metatarsal ligament or plantar fascia and to create a plantar plane to those structures in order to assist the introduction of the ligament or fascia separator. The ligament separator, which is used for separating the plantar and dorsal aspects of the transverse metatarsal ligament from surrounding tissue. The fascia separator, which is wider than the ligament separator, is used for separating the plantar and dorsal aspects of the plantar fascia from the subcutaneous tissue plantar and the first layer of intrinsic muscle dorsally. The IsoGuard device, which is used to isolate the transverse metatarsal ligament or plantar fascia while they are being incised and protect all surrounding tissue. The IsoGuard single-use blade, which is inserted into the IsoGuard device in order to incise the transverse metatarsal ligament or plantar fascia to the desired length. Indications for intermetatarsal nerve decompression. 1. Chronic neuroma pain unresponsive to conservative treatment. And 2. The surgeon wishes to decompress the nerve rather than excising it. The patient is placed in the supine position, local anesthesia is achieved, and the patient is prepped and draped in the usual sterile manner. The foot is exsanguinated with an S-mark bandage, and an ankle tourniquet is inflated to an appropriate level for hemostasis. We are going to decompress the third inner space on the left foot. First, we want to appreciate the relative tightness of the transverse intermetatarsal ligament by moving the adjacent metatarsals. In order to ensure proper alignment of the instrumentation, a line is made with a surgical scribe parallel to the adjacent metatarsals in the appropriate inner space. In this case, the third intermetatarsal space. Using a 15 blade, a 7 mm vertical incision is made in the web space. The incision is made vertically to protect the neurovascular bundle to the toe. A small curved Metzenbaum scissor is then used to palpate and create a small plane on the plantar and dorsal aspect of the transverse intermetatarsal ligament. It is suggested that the instrumentation be placed in saline solution first to allow for a smoother penetration and separation of the tissue planes. The tissue locator is then used to create a plane across the underside of the ligament. Care is taken to ensure that all instruments are introduced in a parallel manner to the adjacent metatarsals. The separator is then introduced in order to isolate the transverse metatarsal ligament from the surrounding tissue and create planes, both plantar and dorsal, to the transverse metatarsal ligament, which will allow for proper placement of the IsoGuard. The separator has an upper and lower prong separated by a 5 mm gap. The lower prong extends approximately 1/2 inch further than the upper prong to allow for initial palpation of the underside of the ligament before introduction and capture of the transverse metatarsal ligament. After removal of the separator, the IsoGuard device is then introduced and positioned securely around the ligament using the same palpation technique used previously with the tissue locator and separator. The IsoGuard design allows for isolation of the transverse metatarsal ligament and protects the nerve and surrounding soft tissue structures from damage during the procedure. The longer lower prong of the IsoGuard is plantar to the ligament, and the short upper prong is dorsal. The IsoGuard has a slotted channel extending through the handle and passing throughout the length of the device, allowing for the passage of the blade while incising the enclosed transverse metatarsal ligament. Once the IsoGuard is properly positioned, the surgeon places the blade through the IsoGuard device until resistance on the distal edge of the ligament is felt. The blade then continues proximally within the IsoGuard, incising the ligament with a controlled cut. When resistance from the ligament is no longer felt, the ligament has been incised. The IsoGuard device and blade are then removed. The tissue locator can be reintroduced to palpate between the metatarsal heads for confirmation of a successful release. Post-op motion between the metatarsals can then be assessed. After irrigation of the surgical wound, the incision is closed with 1 or 2 simple interrupted sutures. The surgeon's preference in this case is to inject a small amount of dexamethasone in the surgical site. The foot is then dressed with a betadine compression dressing or a compression dressing of the surgeon's choice. Indications. The procedure is indicated for chronic plantar fasciitis unresponsive to conservative therapy. After appropriate anesthesia has been achieved, the patient is prepped and draped in the usual sterile manner. The foot is exsanguinated with an S-mark bandage. Hemostasis is achieved with an ankle tourniquet inflated as per the surgeon's predetermination. The surgeon palpates the medial tuberosity of the calcaneus plantar medially. Then, going 1 centimeter distal from that point, a 1 centimeter vertical incision is made. A marking pen is utilized to outline the incision. Using a 15 blade, a 1 centimeter vertical incision is made at the medial aspect of the heel, just distal to the origin of the medial band of the plantar fascia. The incision starts 1 centimeter from the plantar aspect of the heel and ends well below the neurovascular bundle. Utilizing a small curved Metzenbaum scissor, the incision is deepened to start a plane under the plantar fascia and dorsal to the subcutaneous tissue. The tissue locator is then used to extend the plane across the lateral aspect of the plantar fascia. It is important to maintain the plane parallel to the plantar aspect of the foot. The medial band of the plantar fascia is easily palpated with the instrumentation in order to determine the medial aspect of the fascia. The fascia separator is then introduced in order to isolate the plantar fascia between the subcutaneous tissue and the first layer of intrinsic muscle. The fascia separator has an upper and lower prong separated by a 5 millimeter gap. The lower prong extends approximately 1/2 inch further than the upper prong to allow for initial palpation of the underside of the fascia before introduction and capture of the plantar fascia. After removal of the separator, the IsoGuard device is then introduced and positioned securely around the plantar fascia using the same palpation technique used previously with the tissue locator and fascia separator. The IsoGuard design allows for isolation of the plantar fascia and protects the surrounding soft tissue structures from damage during the procedure. The longer lower prong of the IsoGuard is plantar to the fascia and the short upper prong is dorsal. The IsoGuard has a slotted channel extending through the handle and passing throughout the length of the device, allowing the passage of the blade while incising only the enclosed fascia. Both sides of the calibrated cutting blade shaft are marked with 1/2 centimeter increments. They are used as a reference point to the top end of the IsoGuard handle when the blade is placed on the bottom of the foot in the position needed to make the desired length of cut. The surgeon can predetermine the appropriate cut of the plantar fascia, cutting 1/3 to 1/2 of the fascia. In this case, the surgeon prefers to cut 1/2 of the plantar fascia. The surgeon can also use a surgical marker to designate the point of the blade shaft that represents the amount of desired cut to be made when inserted into the IsoGuard. The blade is then placed into the IsoGuard and pushed toward the lateral aspect of the foot. The foot is dorsiflexed in order to place tension on the plantar fascia, and the blade is inserted until it reaches the previously determined calibrated mark. The surgeon can feel resistance while the plantar fascia is being incised. The surgeon can then verify the cut by reinserting the blade without feeling resistance. The IsoGuard and blade are then removed. Prior to closing the incision, the tissue locator can be reintroduced to palpate and ensure that the appropriate amount of fascia has been cut. After irrigation of the surgical wound, the incision is closed with 1 or 2 simple interrupted sutures. The surgeon's preference in this case is to inject a small amount of dexamethasone phosphate into the surgical site. The foot is then dressed with a betadine compression dressing or with a compression dressing of the surgeon's choice.